They will try and teach us ECG, the tips and the tricks of the trade, and make it easier. I've done the course with MD Inc. and I'm still at beginner's level. So hopefully today we will polish it and we will get it to where it's supposed to be. So welcome and enjoy. We will have our ECG questions that the registrars sent through discussed at the end. For now, let's concentrate on what they have to teach us.
All right. Hi, everyone. My name is Sa'ad. I'll put up the talk now and I'll give Jacques and Kamil a chance to introduce themselves because there's a lot of new registrars around. Let me just get to the screen share quickly. Gaudi, will you just let me know when the screen comes up?
There, Mike.
It's up when it looks good.
All right. So, hi everyone. My name is Sa'ad. I'm an EM physician here in Cape Town, based at Khayelitsha Hospital. I'm going to give Jacques and Kamil a chance to introduce themselves and just to say a few words. Jacques?
Yeah, how's it, guys? It's a privilege to be here. It's actually awesome to see all of you or listen to you. It's actually amazing what technology does. I used to work at Vic and left it in the very capable hands of Flip and Seb. And yeah, I miss the team and I miss the teaching and that. And yeah, currently I'm working in Dubai for a familiar company for Mediclinic, and I'm head of the emergency department at the tertiary hospital for Mediclinic in the UAE. Yeah, awesome to be here. If you guys learn something, don't forget to love EM. It's great, no matter where you are. Yeah. Vallabh.
How's it, guys? It's great to be invited to talk to you all today. My name's Kamil, for the registrars that don't know me. I'm really, really excited, and I was chatting to Jacques and Sa'ad. So looking forward to this session for a few weeks already. I used to work at Mitchell's Plain Hospital. I worked with some of you as registrars, probably. A lot of you that are new joinees, I was there for about 6 years. I'm currently working in Ajman. That's like one of the smaller emirates in the UAE. I live in Dubai. I started my Arabian venture in 2018, and it's still continuing. I'm currently the head of department in the ED there, and I work with 6 other consultants. And yeah, really looking forward to sharing some of my ECG knowledge with you today.
All right. Thanks, guys. I'm going to get cracking so long. All right. So how we're going to start off with is that we're just going to have an approach to a difficult ECG. And we're going to go through 5 big themes. And the themes that make an ECG difficult is, are there any clinical factors? Are there some ECG technical issues that we need to address? What are the human and clinician variables that influence ECG interpretation? Just a basic outline of what to do when a rhythm is difficult. And lastly, we'll look at how to be better. And the major theme about how to be better is that, we're learning every single day. And sometimes you just don't know. And sometimes you just need to be able to call a friend. All right. So let's have a look at the clinically related factors. Now, the major theme with ECG interpretation is that ECGs in isolation are not enough to make a diagnosis. You have to be able to take the history and look at other associated investigations that are relevant and tie everything in together. And a very big theme is that always consider the company that an ECG keeps. So both the clinical company and the other associated ECG company. So what that means is that is there something else on the ECG that adds weight to the diagnosis, right? So for example, how we always teach is that if you look at a robber, how does a robber rob? a robber robs with an accomplice and with a weapon, and maybe a getaway car. All right, so there's things that add weight to the ECG interpretation. Old ECGs are always helpful, and we often refer to an ECG as your ID of your heart. You know, in the old days, before we had electronic records, what we used to do is we used to print the ECGs out, and then we used to always give the patient a copy and ask the patient to just put the ECG in his or her ID book. But now we've got ID cards, so that's not so relevant. In any case, all these quotes are not my quotes. They from Jacques and Kamil as well. So I'm just sharing you all the pearls that we've had, all these pearls that we've had throughout the years. Next, let's look at the technical factors that influence ECG interpretation, right? So always have a look at the baseline. Just make sure that there isn't a lead swap. Artifacts makes an ECG very difficult to interpret, and a particular artifact that commonly gets misinterpreted is, atrial flutter for just baseline shivering artifact, or even for sinus rhythm. Make sure that ECGs are always identified, you have the correct patient, and sometimes on the ECG machines, just make sure that you press new patient, right? Have a look at the speed and have a look at the calibration. So this is a very cool ECG that you see on the screen, right? And this ECG initially was interpreted as artifact, but if you have a look very closely, you can see that the patient's got a baseline shivering artifact, and you can see this massive J waves from severe hypothermia. So there wasn't so artifacts sometimes can be helpful in trying to determine the cause. All right, so let's have a look at the human and the clinician issues. Now, our emergency environment is a hustle and a bustle, right? And you get interrupted 5 million times a day. It can be 2 o'clock in the morning, and sometimes you're not at your brightest. So that also affects how you read an ECG. The other thing is that the eyes don't see what the mind doesn't know. And sometimes you need to be taught what to look for. And when you see it again, your memory gets triggered. All right. Type 1 versus type 2 thinking. Often we see an ECG and we just say, yeah, look, this is anterior STEMI, and we leave it at that. But when you have your type 2 thinking, and that's where you must stop and have a systematic approach. And, have a look at associations of what happens together with a STEMI. Is there an associated complete heart block? What's the patient's blood pressure? All those other kind of things plays into account. So as much as an ECG may be obvious in the beginning, it's always important to slow down and have a systematic approach in an ECG. All right. Let's quickly have a look at some rhythm issues. And 2 big themes is that if you're really not sure what to do, have a look at and see and break it down. Is the rhythm bizarre and slow, or is it bizarre and fast? If it's bizarre and slow, the number one thing that you must be able to think about is that is there a potassium abnormality? And then you can go on and have a look at the other reasons that give you slow rhythms, for example, your blocks. Is the rhythm bizarre and fast, right? So when it's bizarre and fast, then you must think, for example, are you dealing with a toxin? Are you dealing with VT, or are you dealing with something like atrial fib with WPW? Right, so those are bizarre and fast rhythms. The P wave is a major scalum, right? And when you're trying to interpret the ECG, try and see if you can find the P wave. And if you can't find the P wave, have a look at your ST segments. Maybe it might just be hidden over there. See if it's not retrograde, right? So try and find that P wave, or maybe there's AV dissociation, all right? And all those things all those things, they give you clues as to what the rhythm might be. Wide versus narrow gets difficult, so it's important to be able to measure. And next, when you're trying to determine whether something is a VT versus a SVT, one of the most consistent ways of doing it is to make sure that you understand and know what are the features of a typical left or right bundle branch block, and whether this is now atypical for that. Right, so a nice way that we teach is that if you look at Jacques, Kamil, and myself, Kamil's a normal QRS complex. I'm a bundle branch block and Jacques VT. So then you can, and often with VT, you know, for example, the QRS complex is more than 160. All right. I don't know whether Jacques and Kamil are cross or laughing at me in the background, but they do remember that. And lastly,
maybe I can just say something there. Just a nice trick. When you, and Saad's always good with it, if you go for rate, find an atrial rate and find a ventricular rate. You know, we've gone past the rhythm. What is normal sinus rhythm? Upright P followed by a QRS. So when you do take your minute to do the rhythm strip, count out your P waves, okay, and also do your PP intervals at the same time, because that will sort of also give you a clue if there's any hidden P wave somewhere. And as soon as there's a discrepancy between P waves and QRSs, you already know either there's something extra on the P wave front, on the atrial front, or there's an extra beat, either PDC, you know, or PJC, something is extra, or is there a block? So immediately you're alerted to that. And then the differentials need to open, you know, what's causing the block? Is it ischemia? What's causing the P wave paralysis? Is it hyperkalemia? You know, as soon as you go through that route, you know, so I think at the registrar level, you know, count the P waves, count the QRSs, that should be bog standard. And that's always a nice way to start off. By the way, Saad.
All right. And lastly, always have differentials, right? So in your guys' pre-reading, you guys had those differentials of breaking it up into narrow and wide, narrow and regular, wide and irregular, those 4 blocks, right? So often, if you ever get stuck, take these 4 blocks and go through it and try and see if you can't interpret, if you can't work backwards from these 4 blocks. All right. So again, if you see a bizarre ECG, remember, always think potassium and tox besides the other stuff that's going on. Right. Lastly, how to be better. Okay. It's not about the diagnosis per se, but first describe what you see. The interpretation will come later, right? After, you always have a systematic approach. Next, validate and invalidate, right? And Kamil always tries to invalidate the assessment. So if you're saying that you think it's this, why can't it be X, Y, and Z? All right. So invalidate your assessment. And lastly, let's have a look at the concept of deliberate practice, right? And with deliberate practice, you must focus and try to be better and practice, and you must get feedback, right? So the big issue around deliberate practice is that if you're saying that you need extra skill with ECG interpretation, there's no use you just take a book and start doing it, but you have to have feedback, and it has to be focus based. Okay. So quickly, just a quick structured approach to ECG interpretation. If you have a look at the A, B's, and C's of it. So how we teach is that you have a look at your ECG primary survey, and then you have a look at your secondary survey, and lastly you put everything together. Okay. So in terms of your ECG primary survey, the big issue here is that, is there an obvious life threat? Now, if you can't remember anything, if you just have a look at it, is the ECG suggestive of an acute coronary syndrome or even a STEMI, or is there a life-threatening dysrhythmia? If not, you can move on to your secondary survey. Try and comment on the most obvious abnormality that you see. Is it too fast, too slow? Is it broad or narrow? And are the STs up or down? This is your quick 10 to 20 second look before you move on. It's sort of your ECG triage, right? It's like everything in life gets triaged. Even if you ever look, even if you go to the gym, right? In the gym, you can see the weights are even triaged, right? So triage, as much as what we want to get away from it, it comes everywhere. Okay. Try to look at as many ECGs as possible to improve your skills and then your pattern recognition, and try to pick up the subtle changes. So that's basically, you know, ECG learning is a lifelong learning, you know, and for us three, the biggest help has been our group and ourselves and us learning from each other. So I'm going to end off over there, and I'm going to hand over now to Kamil, who's going to take over some sample ECGs. Okay, all right. So I'm going to stop sharing now.
Okay, thanks, Sa'ad. I'm going to try and share my screen, so just tell me when it comes up. You should be able to see it now. Can you?
Yep.
Still loading.
Still loading? Okay, we'll give it a few more seconds. Can everyone see it now?
Can see it on my side. All good?
Yeah, good.
Okay, yeah, thanks, Sa'ad, and hello again to everyone. So, you know, just to pick up on a few things Sa'ad said there, which are so important, you know, ECG learning is a lifelong process. You know, by no means do we consider ourselves experts. You know, there's still many ECGs that flummox me, you know, and that, you know, are very anxiety provoking, especially when I can't figure it out. But I think the bottom line is, you know, there's so many resources available. And as Sa'ad said, the one thing that's really helped us is actually communicating between ourselves. I think you have to realize that, you know, you're not going to know everything, but, you know, the more experience you get looking at patterns and looking at different ECGs and testing yourself, the better you'll get. And I think the bottom line is, if you are unsure about something, never be afraid to ask for help. You know, there's always someone you can WhatsApp, there's always someone you can phone. You know, you're making a decision in the best interest of the patient. So don't be afraid to just ask for help if you really need the help. Okay, so this is where I live, just a few kilometers down the road. That's the Dubai Creek. This is my emergency department. So pre-COVID, we were seeing around 200 patients, and we have quite a huge cardiovascular disease burden. So it's not uncommon for us to see a lot of you know, acute coronary syndromes come through our department. I'd say on average, we probably see about 2 to 3 STEMIs a day. And the ECGs that I have for you now are cases that I've had in the last month at my hospital in the emergency department. So I want to try and make this as interactive as possible. So I'm going to ask you to use the hands up function if you have a question, because I think we're going to get the best sort of value for money if you just engage with us and talk to us. So here goes. Let's see if I can do this. All right. So I can't actually see the hands up function now, but maybe Gaudi, if you can coordinate this and actually, you know, pick up on who's lifting up their hands. But I'm going to start off with a little bit of a history, and then, you know, we'll give the audience a little bit of time to look at the ECG. And then if you have any questions or if you have any suggestions or want to put forward any answers, just raise your hand and Gaudi will coordinate it and I'll walk you through the ECG. So just to give you a bit of history, this is a 46-year-old Syrian gentleman. It was actually last week, Friday. So weekend here in the UAE is Friday and Saturday. So he came in around 7 o'clock in the morning, and this is usually around shift change time, right? Our shift change is from 7 in the morning. And one of the ED specialists saw him, and they noticed that this guy was walking, just clutching his chest. So he was triaged up front, and he walked past the doctor's room, and Dr. Noor, who was our on-duty specialist, noticed him walking past the room. Didn't look too well, was clutching his chest, and she actually physically followed him, to the resus area. So the background is that this guy didn't really have much going in the form of past medical history. Smoker, slightly chubby, but no significant, cardiovascular risk factors or any comorbidities, that he had. And his vital signs were stable. He was put onto the resus bed, and this was the first ECG that was recorded. So, as Sa'ad said, your primary survey is just to quickly scan through the ECG. You're going to look at a few things. You want to look at the rate. Is it too fast? Is it too slow? Is it normal? Is there any obvious pattern that you can pick up that worries you? Is there any obvious arrhythmia? Are the ST segments up or down? That's your primary survey. If you can't pick up anything on the primary survey and the patient's stable, then you have a little bit of time to actually systematically go through the ECG. So do we have any volunteers to sort of get us started on this ECG? Gaudi, I'm going to ask you because I can't actually see the hand icon on my screen right now. So if there's anyone lifting up their hands, if you could just coordinate that for me.
Will do so. No volunteers yet at this point.
Okay, come on, guys.
We've got one now. Kagiso is up. Dave Plutus also want to give it a try.
Okay, so you're going to go with the first one. I think it's Kagiso, right?
Kagiso, you can give it a go.
Afternoon, guys. Can you hear me?
Yes, we can hear you, Kagiso.
All right, thanks. Essentially, what I see from this ECG, I can see that he's going at a heart rate of around 100, and I can see what is concerning about the T waves. There appears what looks like hyperacute T waves, especially when you look at B4. And I can see that given the history, I think this guy is having a STEMI. If you look at the anterior lateral ST elevation with reciprocal, what looks like reciprocal changes in the inferiorly. That's what is a bit concerning. But I can see that the sinus rhythm, I can see a P wave followed by the QRS.
Thank you.
Yeah, actually that's what I would be worried about initially.
So what are you saying, Kagiso? Is this a STEMI? Is this something you'd be worried about? Are you going to activate the cath lab? Are you going to thrombolyze this patient?
I mean, given the, I would obviously the history, I would try and get as much as history as I can because the ECG is surely suggestive. So from the history and from this ECG, if the cath lab is available, I would activate the cath lab.
Okay. Dave?
Hi there. Yeah. So, what are you asking me exactly?
Yeah. Okay. Good question. Yeah. What do you think about this ECG? Thoughts?
Yeah, like similar. I think agree with a lot of what Kagiso said. Those T waves are certainly hyperacute. You can fit the QRS complexes under them, certainly in the anterior leads. I don't like the high lateral specifically, and I agree they do look like they're, either whether it's inferior ischemia or reciprocal changes. But again, going with the company it keeps, I'd be very concerned. I'd certainly want serial ECGs. I'd start the ACS protocol for this patient, having ruled out possible dissection, and then I would do serial ECGs as much as I could. If with regards whether activate thrombolize the patient, I don't think he meets criteria yet, say by international guidelines. But again, with hyperacute T waves, it would make me very concerned, and I'd have a low threshold to get him expedited.
Okay, yeah. So thanks, Kagiso, and thanks, Dave, for your comments. So, just a few things on the ECG. So I think both of you correctly pointed out that, the most glaring abnormality are these hyperacute T waves, right? That you see in the anterior leads in V2 and V3. And, the other things that you see are obviously the reciprocal ST depression in the inferior leads. And also, if you look at the high lateral leads as well, there's definitely an element of ST segment elevation there. But, just to talk about a few things in detail on this ECG. So you mentioned STEMI criteria, and, that's one of the things that really bugs me. And the STEMI criteria are totally arbitrary, right? And some people decided that 1 millimeter of ST segment elevation in all the leads and more than 2 millimeters of ST elevation in V2 and V3 constitute a STEMI. But I think the STEMI criteria at best are around 60% sensitive, meaning it misses quite a lot of patients that actually have a STEMI. So I'm sure most of you have read Dr. Smith's ECG blog post, and he often talks about the STEMI versus non-STEMI dichotomy. And people shouldn't be actually thinking of it as a STEMI versus a non-STEMI, but as an occlusion MI versus a non-occlusion MI. And under occlusion MI, you'd get STEMI and all these STEMI equivalents. So what we're actually looking at here is a STEMI equivalent. So these are actually hyperacute T waves. And you correctly mentioned when your T waves are actually bigger than the R wave or your QRS complex, if your T wave actually swallows your QRS complex, you should be very, very concerned, all right? I mean, if you look at V2 and V3 as well, you can see there's the development of these Q waves. And if you look at V4, there's something which we call terminal QRS distortion, which I'll go into in my next ECG. So this ECG for me definitely meets criteria for immediate reperfusion. This is a slam dunk diagnosis. This does not need any repeat ECGs. Again, you've got to take the clinical context into account. This is someone coming in with acute chest pain. He's got these hyperacute T waves anteriorly. He's got the reciprocal ST segment depression inferiorly. He's got the subtle ST segment elevation in his high lateral leads. So we activated the STEMI alert for this gentleman, and our reperfusion strategy is primary PCI. So this gentleman went across for primary PCI, and I'm going to show you his PCI findings. So on the left-hand side, he had a completely occluded proximal LAD, as you can see just on the top bit here. And the circumflex was critically stenosed. And the image on the right-hand side is just post-stenting with good flow in the LAD. All right, so just to reiterate some of the teaching points on this ECG, just be aware about hyperacute T waves, right? Don't always wait for the STEMI criteria. STEMI criteria might be too late. The earlier you act on these patients, the better their chances for a better prognosis are. All right, any questions on the ECG before I move on?
Oh, can I maybe say just one thing?
Yeah, absolutely, Jacques, go for it.
Yeah, so yeah, we all work in different places. If you can imagine you in Vic or Mitchell's Plain in the ED, and this guy comes in, obviously you're going to be worried about the guy. This guy's got a slam dunk, very concerning ischemic looking ECG. He's clutching his chest. It looks like it's going to be either his left-sided circulation, either LAD or circi. The one thing that sort of I want the registers to take, just look at V2, V3, and V4. Just how small that QRS depolarization is versus that completely abnormal T wave. It is dominating the QRS. So repeating the ECG, yeah, by all means, if you have PCI available, the guy's got it. Your perfusion strategy is the guy goes for PCI. By all means, we push this guy to get to PCI straight away. Remembering the dark alleys of reperfusion, you'd obviously repeat the ECG, but I can almost give you a guarantee this guy is going to meet criteria. And if you look at it closely, look where the J point is in V3 and the J point is in V4. So, you know, that is probably going to meet criteria pretty closely. Other thing, just always remember, if you have a look in V1, that T wave is upright, not supposed to be upright. So it's just another nice clue of ischemia, and you've got reciprocal changes 2, 3, and AVF. You know, this guy, you know, reperfusion, yay or nay immediately. I promise you, if you repeat this ECG in 2 minutes time, it's gonna, you know, you won't even need to worry about, you know, STEMI criteria, 2.5, 2 milliliters, what the hell ever. This guy's got chest pain, he's clutching his chest, he's sweaty, looking at this ECG. And the one thing that Kagiso mentioned, it's going fast. You know, fast in a STEMI should already, you know, I don't have a hell of a lot of hair left, but that should make you worry. You know, that heart is taking strain. And the next thing is going to happen, he's probably going to have some PVCs. It's close to an RMT. And if you look at that QT interval, it's already, you know, it's the STs that's pushing that T wave out. Yeah, so just repeating the ECG, yeah, by all means, but get the reperfusion ready, whichever strategy you're going to use. Yep, cool, nice ECG, mate. Love that QRS distortion. Yeah, rock star.
Thanks, Jacques. Thanks for those great comments. You know, so just to get back to you, Dave. I mean, you know, repeating the ECG is not necessarily the wrong thing, but you know, the reason why I wanted to show you this ECG is that, you know, I want you to start thinking, you know, can we make the diagnosis just by looking at this ECG? So absolutely, as Jacques said, if you had to do serial ECGs, I guarantee you in the next few minutes, if you hadn't done anything, or if he hadn't spontaneously reperfused, he would definitely have, you know, the conventional STEMI criteria. So yeah, this guy did well. You know, he made a good recovery, and we subsequently discharged him a few days later. All right, so here's a good one. So this was actually 2 days ago. And what I've done is I've just rearranged the ECGs a bit. So this is a Pakistani gentleman. He is 48 years old. He's hypertensive, not diabetic, non-smoker, no family history of ischemic heart disease, has never been to a hospital before, to any health facility, and has never had any angina symptoms before in the past. So the ECG I'm showing you is the ECG that was done in our department within 10 minutes of arrival. Yeah, any comments? So Gaudi, you're going to have to just facilitate because I can't see the hand icon.
Understand. No hands up yet at the moment.
Scared them off, Kamil. They've gone like chickens into the coop.
No, man. Don't be scared. We're gonna work through this together.
We've got Dave McAlpine and Kagiso that wants to give it a go. McAlpine, you can go.
Okay, I'll give this one a spin. So not dissimilar from the last ECG, but this rate is going at approximately 70, so not tachycardic. It does look like there's a P for every QRS. It doesn't look like there's an element of block. What is noticeable is that there are ST depressions and T wave inversions in your inferior leads. It looks like there's subtle ST elevation in AVL. And T wave is upright in 1. So already we're getting suspicious for a high lateral STEMI. And then looking across at the precordial leads, certainly V2 looks like a hyperacute T. Not too sure if there might be some borderline ST elevation at the J point there. Doesn't really look like it in the leads around it in V1 and V3. And we are sort of looks maybe like some ST depression in V4, 5, and then V6 has flipped its T. So I would be nervous for a high lateral STEMI here. I don't see, sorry, looking at AVR, AVR might also be a little bit up, maybe with an eye of faith. So yeah, I would be concerned for a high lateral, especially given that there are these reciprocal changes inferiorly. I think depending on the clinical picture would then decide whether we decide to go straight for a reperfusion strategy, whatever that is, or if he was maybe pain-free, then we could decide to do a repeat ECG in 15 minutes and get a baseline trop.
Okay, fantastic comments there, Dave. Should we just take the next comment before we summarize exactly what Dave said?
Sure. Kagiso is the next one. Kagiso, you can go ahead.
All right, thanks. I think I agree with Dave. He said most of the stuff that I would say. And then if you look at the question, the concern that I also have is the fact that if you look at AVL, there is an ST elevation there, and that V2 with hyperacute and ST elevation as well. The question that I also would like considering is this is definitely there is an evidence that this guy is having an ACS, most likely like an occlusive myocardial infarction. The question will be like, is it looking at AVL and V2, which are not really contiguous leads? The question is he having a diagonal occlusion? That's what I would think.
Okay, great comments there, guys. So I'm going to summarize what both of you said, and I'm going to try and annotate on the ECG. So, you both correctly said you're quite concerned about this T wave here in V2. It looks hyperacute. I mean, the T wave amplitude is, well, almost the same height, or maybe just a little bit taller than the R wave in V2. The QT interval, if you just eyeball it, doesn't look prolonged. And remember, with hyperacute T waves, you should see a modest prolongation of that QT interval. So that looks okay. There's an upright T wave in V1, which is always concerning, especially in the absence of criteria for LVH or left bundle branch block. I think Dave mentioned that there may be some J point elevation in V2, which is correct, but definitely not meeting traditional STEMI criteria. It's probably about 1 millimeter elevated compared to the TP segment. And then AVL. Yeah, listen, AVL, again, there may be some J point elevation, but if you look at standard lead V1, there doesn't seem to be contiguous change. And then inferiorly, in 2, 3, and AVF, there's quite obvious ST segment depression. So, you've got this middle-aged guy, he's got chest pain, he is a smoker, he's got an ECG which is not normal, but there are definitely a few elements concerning you. So I'm going to tell you what happened with this guy, and then we'll unpack the ECG a bit further. So no one actually looked at his pre-hospital ECG, and Sa'ad also mentioned before in his introduction that always try and look at a previous ECG or an ECG from an old file. And in this case, we had the benefit of a pre-hospital ECG, and everyone missed this. So when I came on shift in the morning, I sort of normally just go through all the ECGs and actually looked and found his pre-hospital ECG. So I'm going to show you his pre-hospital ECG, and I want to ask you if this changes the way you think, or would it change your decision now, having looked at this pre-hospital ECG? So this ECG was done about 20 minutes before he arrived in the ED. This was done by our national ambulance. That's why the arrangement of the leads are a bit different.
McAlpine and Kagiso, you want to give it a go again?
Okay, I'm happy to crack on. So yeah, I'd say this ECG certainly looks a lot more sinister than the one that was done a little bit later on. For one thing, it looks like probably there's a slight ST elevation in your AVR, and then you've got hyperacute Ts in definitely V2, V3, V4, possibly with now ST elevation that meets proper criteria in V2, V3. And obviously those reciprocal changes are still there. So this one very much looks like a STEMI. Oh, Andy's going a little bit more tacky here. So I think if this was the ECG when he came in, this would probably prompt immediate activation of the cath lab. So I'm not sure if he spontaneously reperfused and everything was sort of starting to settle down by the time he arrived in the EC and the next one was done.
Yeah, absolutely. So really, really good comments from you there, Dave. So yeah, I mean, the thing that worried me here looking at this ECG is just looking at these complexes here, right? So this is a phenomenon we call terminal QRS distortion. And if you see it in V2 or V3, you consider this a STEMI equivalent. So just to tell you a little bit more about terminal QRS distortion, terminal QRS distortion is described in V2 and V3 usually. And what happens here is that the S wave is kind of like dragged above baseline with the development of the hyperacute T wave. And when you see this, right, the S wave pulled above baseline, an absence of a J wave and a hyperacute T wave, we call this TQRSD or terminal QRS distortion. And it's almost pathognomonic of an LAD occlusion. So in between this ECG and the first ECG that I showed you, I mean, he had obviously received some aspirin and some, sublingual nitrates, and there was obviously a degree of spontaneous reperfusion before he got into the department. I mean, the other changes are still here. You can see a massively hyperacute T wave in V3 with the existing inferior ST segment depression. So a STEMI alert was not called for this patient, unfortunately. He was admitted to the CCU for medical management, and his troponins obviously returned excessively high. So we use a high sensitivity troponin with a cutoff of 0.014. So his initial troponin returned at 0.4, and I think he peaked around 0.7. So he subsequently went for angio 36 hours later. But I think the teaching point here is, look at the ECGs that you receive with the patient from other facilities, from the pre-hospital providers. Often they can give you a lot of clues. And, just by looking at this ECG and the other one, that would have been enough to call a STEMI alert. Unfortunately, the serial ECGs that he had in the department were pretty much the same like this first ECG. And hence, I think, no consideration was given that this could have been a STEMI equivalent. Yeah, so that's the second ECG. If there's no further comments on this, I'll move on to my last case.
Dave still has a comment? Dave, you can go ahead.
Just a quick question about the ECG that was done in the department.
Yeah.
How is it possible that only V2 has a hyperacute T and all the other precordial leads around it have all settled down? Shouldn't they all sort of either be up or normal? Why is that one stuck around?
Yeah.
Because if you see that in isolation, I think you might say, well, look, obviously if this was an LAD occlusion, surely there should be a hyperacute T somewhere else. But it's just in V2. I'm just wondering why or how.
Sure. Remember, it's all about vectors and people's anatomy is different. And I mean, V1 and V2 are looking at the LAD, right? So you've got a hyperacute T wave in V2, but you've also got an upright T wave in V1, which is also abnormal. And this is what I would consider a hyperacute T wave in V1. If you look at the pre-hospital ECG, what do you notice about your R wave in V3? Do you notice that if you look at your first ECG done in the department, you've got a very good R wave in V3. And if you look at the ECG done pre-hospitally, there's no R wave there.
Yeah, I see that.
Yeah. How do you explain that?
Ischemia, I guess. And ischemia is a cause of your poor R wave progression.
Yeah. For me, that just didn't make sense. If you look at the transition from V1 to V6, right? I mean, it just makes no sense that you have an R wave of this height in V3 or in V2. You have absolutely no R wave at all in V3, and then in V4, you have your R wave again. So I think this pre-hospital ECG, there may have been a lead or electrode placement issue. which contributed to not having an R wave here. So that was the only thing that bothered me, was that there was complete obliteration of this R wave. And then on the one done in the department, we have very, very nice high voltage R wave in V3. But, just to answer your question, absolutely, I think there's hyperacute T waves in V1, V2. These are the leads that are looking, or the electrodes that are placed directly over the LAD. So, yeah, I mean, it's all about vectors. And people have just different anatomy and different positions of their coronary arteries.
Okay, great. Thank you so much.
Okay. All right, so I'll move on to my last case. So this one was on the 25th of August. And I remember getting a call. It was at just around 11 p.m. So this was a young guy. I think he was in his 30s. And essentially brought in by our EMS peri-arrest. He was literally gasping, he was cold, he was clammy, and he was put onto the resus bed. So just some initial thoughts. Does this ECG worry you? Are you concerned? Do you decide to take a break and have a coffee, or do you need to really act and intervene now? So he's actively dying in front of you.
Neville Flook wants to give it a try. Neville, go ahead. And
Yeah,
Kamil's next.
Cool. This ECG would definitely be very, very worrying. I think what the most striking feature would be is the very slow ventricular rate. That's probably around going between 20 and 30. There's some regular P waves that I can see in between the QRS complexes. This looks like a very slow ventricular rate, concerning for a 3rd-degree heart block. I would jump to pacing.
Okay. Kamil?
Hi, can you hear me? Sorry.
Yep, can hear you.
Yeah, very concerning. As Neville pointed out, the other thing that's concerning here is the number of P waves. So it looks like it's got the P wave axis is normal, so it looks like a sinus tachy. So definitely he's sick and his heart is feeling strained. The other thing that's to note here is I think that P wave, the PR interval on the rhythm strip from the second complex, the second sort of QRS complex to the next one actually looks like it gets shorter. So that's not in keeping with any sort of 2nd-degree block. So most likely a 3rd degree with the sinus tach. It's difficult to ascertain where these complexes are just because of where they start and end. So looking at V1, I don't know if that's part of the QRS from V1 or in AVR or what's going on there. But from the history, especially concerning for he's developed a 3rd-degree heart block from a conduction issue secondary to ischemia. Needing immediate sort of a pacing, temporization, and a reperfusion strategy to try and prevent him from going into arrest.
Okay, yeah, so both of you are quite correct. This ECG is very concerning. This is not an ECG you run away from. It's not a patient you run away from, obviously. And you need to act, immediately. But I think you all have just, quite correctly described that there's an obvious block here. It's a slow rate. I mean, it's going at 1, 2, 3, 4, 5, so about 30 beats per minute. And I think both of you correctly said that you can sort of kind of pick up the P waves here. And P waves are pretty regular if you map them out. And the QRS complexes are also quite regular. So there's definitely AV dissociation. We're dealing with a complete heart block. Any comments about the QRS morphology and these complexes? I know Kamil mentioned ischemia and you talked about a reperfusion strategy, but just any comments on these QRS complexes?
Kamil, there's no specific comment about the QRS complex, but Midi is exclaiming in the chat, potassium, !2.
100%. So whoever whoever raised that, whoever brought that up, fantastic. You know, there's always time to do a VBG, and absolutely, when you have a slow, bizarre rhythm or a rhythm that you can't explain, or if the ECG just looks weird, you know, always check a potassium. That's a fantastic suggestion, and we did, and his potassium was normal. But that's an excellent comment.
Sorry, Kamil. It's difficult for me to tell, but you know, especially in V2, it's starting to appear like a right bundle type morphology. But you know, V6 is difficult. As I said, you know, where V1 actually starts, you know, how much of that belongs to the QRS complex. The T waves are upright. It's very drawn out, very long. Very worrying that if he's got a, you know, taken out the right conducting system, and I don't know, proximal LADs still to the first septal perforator. Yeah,
no, absolutely, and that's the point. You know, I mean, the thing I wanted to highlight is, you know, people get so enveloped in the conduction issue and the heart block that they actually forget to look at the QRS morphology and look at the other things on the ECG. You know, because a block doesn't preclude one from actually evaluating the ST segments and the T waves.
Dr.
But
Vallabh,
yes, Gaudi.
Sorry, I think Kagiso and Jonathan wanted to give a go just before you reveal the golden answer.
Okay, absolutely. I will come to them. I'm not going to reveal that golden answer yet, but you know, just to say that, you know, don't get sort of trapped or lulled into just the block bit of it. You know, try and just look at every lead and just try and scrutinize the ECG in a systematic way as you would otherwise. And I agree with Kamil, you know, these QRS complexes are very bizarre. You do get the impression looking at V2, it looks like a right bundle, although it's not typical, especially if you're looking at one in AVL, you don't expect that in a right bundle. And then obviously V6 doesn't really meet that right bundle branch block criteria morphology. So absolutely, you know, there's something bizarre going on there, and we'll see what evolves in the next few minutes. So Gaudi, yeah, we'll take some comments.
Kagiso, did you lose courage or are you still willing to comment? Otherwise, Jonathan can go ahead.
No, it's fine. Jonathan can go ahead.
Jonathan, the floor is yours.
Hi, Gaudi. It's not Jonathan, it's Emily. Sorry about this. We're in the middle of Novata. I hope you guys can hear me clearly.
Yeah, we can hear you.
For the ECG, I just wanted to comment on the QRSs in the inferior leads. We've just noticed that there's a possible Q waves in the inferior leads, which in the setting of a heart block, you would wonder if there was a previous ischemia causing the heart block. The question, however, is why is a 30-something, I think you mentioned a 30-something-year-old having ischemia and going into a heart block. I can't think of that. But then I just also wanted to raise the question in terms of looking at the QRSs with these heart blocks. There's a possibility that the QRSs are coming from a ventricular rhythm. Can we still comment on the QRSs if they're coming from somewhere that is not the SA node, normal kind of conduction pathway?
Yeah, so great comments there. So I think your name's Emily, right? If I got it correct.
Yes, yeah. Emily.
Yeah. Yeah, so I mean, Emily, I mean, yeah, good call on the inferior leads. I mean, I do get the sense that there's a bit of a small R wave here, you know, inferiorly. So I wouldn't really call them Q waves. So I think they're more RS complexes inferiorly. But just to go back to your comments about the QRS morphology, absolutely, you have no idea where the escape is coming from, right? So currently at this point, with the QRS morphology looking so bizarre and the fact that it doesn't actually fit either typical left bundle or a right bundle morphology. So I think the point here is, you know, as you correctly mentioned, this is a young guy, he's in his mid-30s, you know, he's coming in peri-arrest, you don't really have much more information and he's in a complete heart block. You know, how many 30-year-olds do you see in a complete heart block, right? So this was quite concerning, obviously. And I think as Neville pointed out, you need to just act immediately. He would have done transcutaneous pacing. And this is what was done for this patient. So he was started on TCP and was also started on an adrenaline infusion. And this is the subsequent ECG done a few minutes later. So by that time, after pacing and the adrenaline infusion, he perked up a bit. His blood pressures had improved, his mental status improved. He started looking a lot better clinically. So, yeah, this is the ECG.
Kamil still has a few comments in the chats. You want to discuss them, Kamil? Kamlin?
Yeah, well, now that I've seen the reveal, yeah, it definitely looks now like he's got the right bundle STEMI, something, it's LAD taken out before the first septal perforator. He's already got Q waves in the sort of septal leads, and his rate is going faster now. You said he was being pacing. I can't really see that there's, pacing being captured here. Maybe I just can't see it properly, but very, very, very concerning, and definitely needs a reperfusion strategy ASAP.
Yeah, so was being paced on demand, but also on an adrenaline infusion. So I think obviously once his heart rate hits a certain target, then the pacer, doesn't pace. So correctly called, yeah. I mean, you can see now clear right bundle branch block morphology, with the deep S wave in V6. And you can see definite elevation at the J point, indicative of a really proximal LAD occlusion, as you said, prior to the first septal perforator. So this is a right bundle with the STEMI that was complicated by a complete heart block. Unfortunately, he didn't have a good outcome. He subsequently demised en route to the cath lab. Yeah, so this didn't end up being a good outcome for this gentleman. But yeah, guys, those are my 3 cases. So just to summarize some of the teaching points from my 3 ECGs, beware of the traditional STEMI criteria. If you're going to wait until those criteria develop, you may miss that window of opportunity to get your patients reperfused. So be really aware of those STEMI equivalents, and the ones that we often miss are these subtle hyperacute ones, the terminal QRS distortion, the De Winter pattern. These should be treated exactly like STEMIs. They call STEMI equivalents. And then just some pearls on the last one, just don't get completely, enveloped in the heart block. Try and always ask yourself, what's the mechanism of the heart block? Try and associate it with the history. Always try and come up with the differential diagnosis, and then just repeat the ECGs. Okay, Jacques, I think I'm going to hand over to you, or Sa'ad. I'm going to stop sharing.
All right, so what I'll do is that I'll share on Jacques' behalf. Let me just get the screen share.
Got the ECG, mate? Yeah, perfect.
Yeah, okay.
Okay, who wants to have a crack at it? So can't really, no suspicion of a toxidrome or anything. Patient came in with palpitations. Yeah. Anything that jumps out? And yes, no. Yes, go for it, young man.
Hi, Jacques. Okay, let me give it a crack. The first thing that jumps out is this rhythm is irregular.
Cool.
But just looking at so I'm going to start with a rhythm. So looking at the rhythm strip, we can see that there is a P that follows the QRSs. The P's are in the right orientation, so it looks like it's coming from the sinus node. However, this appears to be looking at it now, every third sort of P where there would be a P. I'm not mapping it out properly, but it looks like where there's a missing sort of QRS complex, it actually falls halfway between the 2 preceding Ps. So because every P follows every QRS, it's not going to be a second degree, but I think that there might be something with the SA node. So it might be like a sinus exit block or a failure to just generate the P wave, and then it continues along the same pattern after that. So primarily I would be worried about a sinus node issue. Towards the end of the rhythm strip in lead 2 especially, you can see that we've got that same pattern of P wave, and then suddenly there's a premature something that's coming up there, which is sparking the same sort of conduction system, creating that, I don't know, premature atrial beat, which is conducted. And then we have the thing continue again. Just briefly looking at the rest of the ECG, it appears largely normal. I mean, there's nothing striking about the ST segments. Maybe a bit of a high R wave in V3, but nothing really. And then the R wave there's a bit of R wave poor progression from V3 all the way to V6. The atria appears normal, maybe a bit of a broad P wave. I'm not too sure. I can't really see the dots here, but yeah, that would be my biggest concern here is some sort of sinus node issue, exit block, or a failure to generate.
Okay, great comments. So it's easy. So if you look at the rhythm in general, so what I always, if you take Kamil's previous case where we decided to pace immediately. So when you start thinking about pacing, you need to ask yourself 2 questions. Is it the slow heart rate causing the symptoms, or is it a poor EF? So you brought up a few good things. So just looking at this heart in general, would you say this is a normal ejection fraction or a decreased ejection fraction? And there, just remember for the guys and girls, you want to look at your R waves. In here, you're looking at your precordial leads. So knowing what your precordial lead should like from V1 to V6. If you have a look here, the R wave in V3 is more than 3 millimeters. It dominates in V3 and V4, and then it gets smaller. So, you'd sort of estimate that this is probably not going to be an ejection fraction issue. The rhythm thing, the interesting thing is when you start looking at SA nodal blocks, they can be pretty tricky on the surface ECG because you don't really have anything to measure it against. AV blocks are easy because you've got a P wave, which is coming from the sinus node, and then the delay you can measure against the QRS. With the SA nodal block, with the SA nodal block, you don't really know where the P wave was before. Now, can I ask the guys, is there anything that bugs you? Look at there's a group pattern here. Is there anything that bugs anyone about what that second T wave looks like every time? Sa'ad, can you sort of draw one of these cute circles around that second T wave, mate? Yeah. There we go. Is there anything maybe, if you compare it to the one before that, what do you guys think might be hidden in there?
Probably a P wave.
Maybe wants to give it a try.
Yeah,
go for it.
Yeah, I just wanted to say it looks like there's a hidden P. There might be a hidden P in that T over there.
Okay, and Kamil actually gave the answer. He just didn't realize it just yet when he said something about a premature atrial complex.
Yes. So
yeah. Go for it.
No, so usually what I do with the grouping is I've got a differential. So if I see grouping beats, I think of Mobitz 1 or 2. So I go map out the P waves and see if there's any hidden P's in the T's. The other thing that's on my differential is the premature complexes, so your PICs and your premature junctional complexes. And the other thing is also hyperkalemia. So in this case, it looks like a premature atrial complex for me, but I'm not the best.
Okay. No, I like that. So just on the surface, when you quickly glance at it, you almost want to say the PR interval remains constant and we're dropping a QRS. Could this be Mobitz 2? Okay. The big thing to remember that then your PP interval should remain constant. The same. Yeah. And here, if we're saying that third P wave is hidden in the T wave, that's actually a premature P wave. Okay. All right. And then what has happened is at the fourth group, where Kamil rightly said was there's the QRS it's now conducted. So what sometimes can happen is if the premature beat is so premature, and it happened in the first 3 groups of these of this rhythm, the QRS actually did not conduct down the fascicle. So this was called the Mobitz 2, all right, in the unit. and went up to cardiology. And later on, the EP guys said, no, just hang on, it's probably not that. So what happens there at that fourth little beat, at that stage, the fascicle is actually ready to conduct. So this is actually a trigeminy, atrial trigeminy. So every third beat is a premature atrial beat. And at that fourth group beats, that QRS actually conduct, and that's called Ashman's phenomenon. Now, you ask me, Jacques, is it really that important?
Sorry, Jacques.
Yeah, go for it.
Kamil just wants to add a few words.
Sorry, my hand it was up from last time. Sorry, don't worry.
No, go for it, but what's up?
No, my hand was up from before. I don't have anything new. I think I was just going to ask if this is not but now you've already said it's Ashman's. I was thinking about decremental conduction in a sort of.
Yeah. So Ashman's is normally well described in something like AF, where you have that very premature beat. So all of this basically means if for most of us mere mortals, what I sometimes think of, every part of the conduction from the P wave through the AV node to the QRS, everything has got a depolarization time and a repolarization time. So what has happened here, that fourth time that P wave was conducted, so just maybe put a circle around that bugger where there's a premature QRS. Yeah, you got right, good. Right.
Yeah, mas.
Okay. More. That premature beat, the second last beat, mate.
Here we are.
Yeah, that's one. Yeah. So just focus on that. If you have a look, so we're postulating that there's a P wave hidden in every second T wave. Okay. What has happened that the fascicle then did not conduct. So the P wave is so premature that the QRS, the signal going from the P wave down the AV node to the QRS, down the bundles, happened too soon. So the fascicles were still in an absolute refractory period. Now things can obviously influence that. So things that normally bugger around with your reperfusion or your repolarization is obviously electrolytes, ischemia, drugs. Okay, so beta blockers, calcium channel blockers can do that. So that should all flow through your differential. This is just a nice example from a rhythm point of view, is try and find every little beat. And the other thing is about the morphology of the T wave. T waves rarely changes shape, okay, unless the patient is severely hypokalemic. All right, that is the one thing to always consider. Hypokalemia can give you T wave alternance. All right, so where your T waves are different sizes. The rest of the stuff, the T wave actually remains the same. And the clue here is that all of a sudden your T wave has changed, and that is a hidden P wave there. The other phenomenon that you see is there is fascicle conduction that happens only at the fourth group. And that's about it. So the patient actually had an EP study, wasn't too bad, got treated for his hypertension, and he flipped back into normal and is following up. All right, is there any other questions on it? Did we go too fast? Anyone else wants to say anything? Yes, no, probably no. All right, so in essence, when you go through rhythms and stuff, always count the P waves and the QRSs. Sorry, you need to go back, Squire. Yeah, there we go. Count the P waves, count the QRSs, and then when you look at the rhythm strip, scrutinize the contours of your QRS, the P wave, everything. SA nodal blocks, first degree SA nodal blocks, you won't be able to see on the surface ECG because you've got nothing to map that P wave against. The phantom P wave where it should be, you just don't know. First degree Mobitz 1, what you'll have, your PP interval will slowly increase, but your AV node, the AV conduction time will remain the same, and you'll drop a P wave. Right, and that's as rare as N, Steve. Someone finds a nice example, go for it. Mobitz 2 SA nodal blocks, I've seen one or two. It can look very similar to this, but not with that hidden P wave, and the PP interval needs to remain constant, right? Okay, this one is too premature, and this one would have looked like it, but the P wave would have been chopped. Complete SA nodal block, you'll have an escape rhythm. All right, and that sort of boils down into an exit block where the P wave is much later than it's expected. All right, cool. Next one. This one. Okay, I'll give you guys a little history. So he was a 60-year-old Hungarian guy, patient that came in. He's had previous VT, he had an ICD in, and he was on amiodarone and bisoprolol.
Was he stable, Jacques?
Yeah, he was stable. He was chatting to me. Blood pressure was okay. Well, blood pressure was about 95. Like I said, he was on a beta blocker and he was on amio and he had an ICD placed already. The ICD didn't go off, and then this was the rhythm we faced. So, you know, what do you guys think? VT, SVT with a bundle branch block, sinus tachy with a bundle, anything, slow VT? What's the thoughts? What did you do next? We actually got we interrogated the device. So he obviously had an ICD with a pacer in. So the device showed us very nicely that there was AV dissociation, which we could see. So AV dissociation, obviously, you know, from an electrophysiological point of view, means that there's then VT. It's a lot slower than you expected, and that's because he's already on amio and a beta blocker. Remember, normally your VTs will sit in a range between 160 and 180. And we'll get back to the morphology of it now. We actually overdrive paced the guy. So we turned the ICD on, turned the pacemaker on, and we put the rate up to about 180. He flipped back into sinus, and the patient was very happy, and he went home. We just checked the potassium, and all was there. So, sorry, if you can maybe just, it is beat number 5. Yeah, what do you guys think that is? If we would recall, if you think about features of AV dissociation, there's normally 3 of them that are fairly easy. Who wants to just have a stab? What is the 3 features of AV dissociation in a wide complex rhythm? Yeah, Kamil, you want to go for it?
So that, I don't know, it looks like a fusion beat.
Yeah. So yeah, it's pretty, you don't see it very often. So a fusion beat just means that the signal from above the SA node or from the SA node and the signal from the ventricle is fired almost at exactly the same time, and planets align, and all of a sudden the QRS looks slightly different. And like I said, this is probably the only good example I found from clinical practice. So fusion beat is one of the rarest signs of AV dissociation in the setting of a broad complex rhythm. What's anyone for the other 2? Yep, Dr. Layton, Dr. Mkalpini.
A capture beat.
Yeah, good. So capture beat, what would that look like?
I think it's when the beat sort of looks more normal than the abnormal, because the electrophysiology gets captured again.
So it's sort of like almost in
the midst of everything else.
Yeah, so if you guys can imagine in that rhythm strip at the bottom, all of a sudden you have a P, QRS, T complex, and then it just goes on. So that's one of the more common signs of AV dissociation. And all that it points you that the signal is actually coming, you know, it's a ventricular rhythm, and all of a sudden planets align, the P wave fires, it happens while that ventricular focus is still an absolute refractory period, and it conducts down. And it can actually sometimes flip it back. Yes, Dr. Layton, I see a hand.
Hi, Jacques. I was going to say capture beats as well.
Which one? Yeah, and the other one, the last one? Fusion beats, you mentioned the rare one, so I showed you the rare one, the hen's teeth, and then the capture beat, and then non-conducted P waves. So normally what you guys want to have a look, especially in broad complex rhythms, is to have a close look in V1. That's normally your money shot in broad complex rhythms. And then look for these P waves that are not conducted. So you sort of have these P wave that sporadically appears in the rhythm strip in V1 or 2, and that just helps me. Is there anything else on this ECG that might point you in the direction that this could be more ventricular rhythm? What else helps us? in this ECG?
Hi, Jacques. So the initial depolarization of the QRS is very slow.
Okay.
So it looks like it's not using specialized conduction tissue, especially in V2. So that initial half of the QRS is very long. So it would make me more think of VT.
Yeah, so, you know, remember what Sa'ad said, you know, Kamil's nice and thin, Sa'ad looks cute, and I'm very broad, all right? Okay, so if you think about the initial part of the QRS, so when you're looking at broad complex rhythms, now just on that, if you are too wide, like really wide, so if you're going to go 180, 170 plus, what I want you guys to just take a pause with that patient. Yes, they are on a very, you know, bad rhythm, but those are the ones you need to start thinking about electrolytes and toxidromes, especially sodium channel blockers. You know, your TCA that comes in, you know, patient who comes in seizing with a rhythm like this, you're going to grab that bicarb and get the tube ready, all right, before starting to defib the patient. Because if it's really wide and bizarre, just remember toxidromes and potassium. Now, this guy is completely stable. What Kamil pointed out is just the morphology of your QRS. If you can imagine, if it was a bundle branch block and the signal was coming from above the bundle of S, so, you know, just below the AV node, and the signal is coming by the SA node coming down, there's a re-entry circuit there. The initial part of the QRS should be quick because it's coming from normal conduction tissue. And as soon as it hits the bundle, it will pause. This one is different, and V2 is a nice example of it. You can see that as the conduction happens, it's not going through, you know, pacing or, you know, conducting tissue. It's actually slowly depolarizing through the ventricle. So that's also a nice clue that it is more of a ventricular rhythm. The other thing there's, you know, and I'm sure the questions the guys, Dave and Kamil and everyone put it up for later, goes about, is there any quick ways of doing it? You know, if it's wide and bizarre, it's going to lean towards VT. And, you know, then you can start looking at it. And we can go through the Brugada algorithm if we go through your guys' questions in a little bit. So maybe the last one.
Jacques, just before you move on to the last one, can I just ask you to clarify, just for we have some quite junior registrars on the group, but even just as a recap for the seniors, what would be the value then, particularly in this patient, just around thinking about overdrive pacing, given that this patient had an ICD in situ? So you know, like, what is that?
So what the idea was that you actually, it's almost like defibbing the patient, but using the rate instead of just stunning the heart. So, you know, what you're trying to do when you overdrive pace is actually you need to abort that ventricular circuit. And if you go fast enough, it will happen before that the ventricle can depolarize. So the only reason we did it in this case is because the guy actually had an ICD in situ. And we could actually pace him through that, because you can imagine this guy would not have been super keen for us to overdrive pace him transcutaneously. This was an ECG, it was normal VT. What we would have done is obviously we would have sedated the patient and we would have sync cardioverted. As you're going through the motions and getting ready for that, we'd obviously take the potassium, get the IV line up, make sure the oxygen is ready, you know, go through your H's and T's. Is there potential for a toxidrome? If the answer is yes, young patient came in, there might be TCAs or carbamazepine involved, then by all means you're going to give some bicarb and then maybe try and cardiovert the patient. So yeah, no, great question. So this is probably the first time I've actually seen an ICD and a pacer used to actually overdrive pace, and it was just such a cool case. I thought I'd share it. It's not something I've seen before. Other thing, just on the specific one, it's fairly slow. You know, one would expected it to be a little bit faster, and that's mainly because he's already on a beta blocker and calcium on amiodarone. And that's the reason his ICD didn't go off, because it was set at a certain rate. It's normally set about 170, 180, and this was too slow. So his medication actually made the machine not work properly. So does that sort of answer the question, madam?
Yeah, I think that's great. Thank you. That really clarifies it for the group.
Cool. What I'll do is I'll try and find those, the video of where we overdrive them, and I'll send it to you and you can share it with the guys.
Brilliant, thanks.
Okay, so I can't see you guys now, so just give me a shout for hands up. Who wants to take a stab at this one? Patient came in, blood pressure about 80, a little bit swollen, KVP up a little bit. Yeah, what are we going to do? Welcome back, Sa'ad.
Are we on the right one?
Yeah, I'm sharing now. Giving up hope on you.
Yeah, man. My network was Jamakar.
MTN.
Yeah.
Anyone want to have a stab at it? Okay, would you guys say it's regular or irregular? Fast or slow? How would you go about it?
McAlpine wants to give it a go.
Dr. McAlpini, yeah, go for it, mate.
So it's narrow complex. It looks irregularly irregular, with relatively small complexes, but doesn't look like any electrical alternans. So just with narrow complex irregularly irregular, top of your list would always be AF. But in this case, it does look like there are P's potentially. So I don't know. I think it looks like there are different P wave morphologies. So my guess would be multifocal atrial tachy. Doesn't look like flutter with variable conduction. But every time I've ever said this, it's ended up being AF. So probably it's going to end up being AF, but I'm not sure.
Yeah, so I think, mate, that's a good start. You know, whenever the things is irregular, you know, money shot is on AF. And just always remember for everyone, AF and multifocal atrial tachy hunt together. So, you know, one day you can pop in from the one to the other. And, you know, Dave, whenever you see AF, what sort of what do you think of? Because I think we take a back seat in AF. You know, it's actually one of the cooler rhythms that we have. You know, so this patient is reasonably stable, blood pressure is sort of, you know, systolic is sitting about 90, 95. You know, what would your next step be? What are you going to do, mate?
Yeah, so as you said, his rate is pretty fast. I think he's going at about 140, 150.
Yeah.
So it's obviously a fast AF. So if he's stable or not, we've got a few options. It depends. Firstly, okay, if he's very unstable and we think he's sort of like peri-arrest, which this guy doesn't sound, then we have to shock him. But it sounds like we've got some time in this guy. So we need to try and find out how long he's been in AF for. Has it been a relatively short go, or we don't know?
So this guy is telling you, no, doc, so he's hypertensive, he's a diabetic patient, and he tells you, no, doc, I'm not aware of palpitations at all.
Okay, so we basically don't know. We have to assume it's been for a while.
Yeah.
So in his case, we definitely aren't really looking to rhythm control him. So probably rate control would be our way to go. In his case.
Yeah, so imagine you at Mitchell's Plain in the ED, you know, just take the guys through how you're going to sort of, you know, go through the motions of working the guy up. Yeah.
Okay, so he's got all the risk factors for it, but if it was a first presentation, we'd always want to get his TSH just to check that this isn't a subtle presentation of hypothyroid. And then obviously you want to get your electrolytes. You always want to get potassium with any arrhythmia. And obviously ischemia can be a trigger for AF. So we'd want to just question him about any cardiovascular risk factors, any chest pain, which could always be a bit of a chicken and egg story with this, but you'd always ask that anyway. And in terms of his management, obviously you'd want to put him in resus, get him on a cardiac monitor, get decent IV access, keep a decent eye on him because he's not very stable.
Yeah.
And then I think your options are for him, you could either give a beta blocker or calcium channel blocker like diltiazem, which we don't really have. But with the low blood pressure, I would be a bit iffy because if you tank his BPs without slowing down his rhythm, you could get yourself in trouble. Yeah. So I think probably better option would be either DIG or amio, I think would be the two that I would.
Yeah. But how are you going to make that decision? So you're obviously on the floor, the patient comes in, and rightly so, you've decided, let's rate control the guy. He's going pretty quickly. And just, if you guys think about AF, just always remember that, you know, the problem with AF in a 20-year-old that goes fast is not really going to cause a huge problem, because you've got such a good cardiovascular reserves that if you lose that atrial ventricular synchronization, you know, it doesn't really matter. You know, you still will have the ejection fraction and good cardiac filling, you know, that you will perfuse your brain, you'll perfuse your kidneys, you'll perfuse your coronaries, and you'll be okay. As the people get older, they run into trouble. And that's normally where these kinds of things come in. So would you order a chest x-ray, mate?
Yeah, always a good idea to order a chest x-ray. It could show us if there's a bit of pulmonary edema. It might show us if there's a big left atrium, maybe like an underlying valvular disorder.
Yeah, so just thinking about, so just always when you think about AF, you know, what I want the guys to focus on is think about an etiology. So AF is like constipation. It's a sign. You know, you have to think about what has actually caused it, because if you're telling me, Jacques, this is mitral stenosis with a big left atrium and the EF is okay, you're going to beta block the guy, right? If it's an ischemic cardiomyopathy, right, and the patient's EF is poor, you're probably going to use a more cardioselective beta blocker, you know, diuresis the patient, and then, you know, slowly introduce a beta blocker. If it's a lady that's postpartum, for postpartum cardiomyopathy, then obviously very careful selective beta blockers, maybe a little bit of aldactone, careful Lasix, you know. So I think the take-home message on this ECG is, yes, it's probably AF. Could it be MAT? It's all academic. The one nice place to look for the ventricular alternance here for me is always V2. For some reason, it just, if you look, we always look at the upright alternance. But what we forget to do is where you see the little R wave going up, and you see at the bottom of the S, and you see what the QRSs are doing, Dave?
Yeah, I see them.
Almost, yeah, you almost like makes a hyperbole. So there is some alternance there, and you know, you get what we call depolarization and repolarization alternance. So the faster the heart rate, the more likely you see depolarization alternance. So take-home message, what I want you guys to do is, if you ever have an SVT or fast sinus tachy, just go have a look, and you pop the probe on, and there's no pericardial effusion. You actually, due to the heart rate being very quickly, you can actually have depolarization alternance with that. The other thing you can obviously do is, if you also think about a pericardial effusion. You know, let's say this patient is at TB, he's 3 months into treatment, and he's noticed his leg swelling, he's got dyspnea and that, then obviously this could be a pericardial effusion. The most common arrhythmia you get in TB pericarditis, TB pericarditis, AF, all right? And you treat the TB, and obviously it slowly gets better. All right, so yeah, it might be a good approach. You know, like I said, AF for me is one of those great rhythms, you know, so you need to target what the etiology is, because if you know what the etiology is, it will just guide your approach. And, you know, not having diltiazem, yeah, whatever, yeah, you know, we have enough beta blockers in South Africa. You know, at Tenelor, you'd go for rate control, preserve the ejection fraction, and Carlock, you can obviously use it. The EF is decreased, but just use it very, very carefully. And if you rapidly need to correct the heart rate, then obviously you can try some amio. It's not ideal because there's a small chance you can flip it back into sinus, but you know, then it's life over limb. Yeah, cool. Yeah, mate, go for it.
So, do you ever use DIG, or you think it's old? And
yeah, so DIG is a great drug. So you know, I've actually used it more now again, because we really have some oldies here in the UAE. So we actually have seen some DIG use. So DIG is actually fairly well for symptom control. So you know, remember, it gives you inotropy, decreases chronotropy, and helps with AV conduction. So it slows down that AV conduction part of it. So yeah, you can use it. And by all means, you know, if you have a 70-year-old in the AF with this, and you know, grade 2, grade 3 baseline, yeah, DIG is a great drug to use, but just always be careful. If you can follow it up reasonably closely, and start slow and make sure that the patient doesn't become toxic and it's a good family, then by all means, ditch is definitely an option. But you can always add a little beta blocker with it and start slow with ditch. Yeah. But in the acute setting, to be honest, I haven't really used it much. Yeah.
Is there not a risk with treating these guys with low blood pressure if you give them your beta blocker, especially if you give them like a non-cardio selective one like a tenolol? Is the risk not that you might tank their blood pressure further, and then if you don't slow them down sufficiently, then you're in trouble because you can't take it back once it's in?
Yeah, it is. But just remember, in this setting, the problem is in fast AF because you have this fibrillating atrium not filling the ventricle properly. So one, you've lost your atrioventricular synchronization. So you need to give the ventricle time to fill. So you want to slow the ventricular rate. That will improve your cardiac output. I wouldn't go give this guy 50 milligrams of atenolol. That would just be silly. You'd start slow, because the one thing I would have done is just pop a probe on the guy's chest and see what the EF is. If the EF is low, then obviously you start Carlock 6.25, diaries the guy a little bit. That's if you're thinking ischemic cardiomyopathy, postpartum cardiomyopathies, drug-induced cardiomyopathies, which we saw a lot of, then you're going to start slow. If it's mitral stenosis, blood pressure is 90, you can give some atenolol because that ventricle is resting its whole life through a stenotic little valve. So, in that case, atenolol will be fine. You need to slow that down fairly quickly. It's a great point, mate. So I think Dave's made a good point there. Just be careful when you slow them down. You need to just think can the ventricle sustain a beta blocker? That is the question that needs to come in, and how much of a beta blocker. Yeah. Does that sort of help a little bit?
Yeah, that's perfect. Thanks, Jacques. Thanks very much.
Yeah, no stress, mate. Yeah.
Perfect.
Almost there. All right. Can you guys hear me? So basically, this was so we've been trying to put some of this stuff together, and there's two other ECGs now. So this is a 70-year-old gentleman, diabetic, hypertensive, smoker, came in with severe central crushing chest pain. All right. Does anyone want to have a go?
Kamil wants to give it a go. Kamil, go ahead.
Hi, Sa'ad. So starting off, the initial impression is that I'd be very worried about this ECG. So the obvious abnormalities is he's got ST segment elevation in the inferior leads with reciprocal changes in 1N AVL, as well as some evidence that the ST segments are showing us that he might have posterior extension. The other concerning thing is that he looks like he's got AB dissociation. So there's a sinus tach and the P waves look regular, some buried within the QRS complex. And the QRS complex is a self-R regular. So it looks like he's got a third degree AB block with a junctional escape because the QRS looks a bit narrow, secondary to the ischemia from his inferior MI with posterior extension.
Yeah, I know. That's excellent. I mean, if we were marking an OSCE, you'd probably marking a VAQ, you probably get full marks on that. So I think the big thing here, the other points that I do want to emphasize, besides for the STEMI, you guys can appreciate that you have an inferior STEMI with posterior extension. And whenever you have an inferior STEMI, just make sure that you also are on the lookout for a block, whether it's a first degree, a second degree, or a third degree. And then again, the points that we're emphasizing is that you can see these P waves, they are hidden in these ST segments, and these ST segments are becoming distorted, right? So just have a look there. The other point is that whenever you do see an inferior STEMI, just also have a look and make sure that it's not an RV infarct. And you should do a V4R on that patient, have a look for associated posterior extension. And the other differential, the other point together with an inferior is to make sure that there's not a block. And the last thing is there can be another vascular catastrophe as a mimic. Do you know which one, Kamil?
Yeah, so especially if you're looking at the RCA, then you would think of an aortic dissection involving the right coronary ostium.
Yeah, so that's the other mimic that you must just be very wary about. Okay, all right. So that's it for that. That's it for that ECG. We're going to move on to another one. So this was a very, very, very exciting case, and this was a 65-year-old gentleman who came to us with a chief complaint of generalized body aches. And we noticed he had a temperature of 39 degrees Celsius. And his ECG was initially interpreted as him having an SVT. And he got sync cardioverted. And he had no response to the sync cardioversion. So I got called and we went back and we examined the patient. We found some interesting clinical signs, and we went back and had a look at the ECG, and the ECG was really fascinating. You might want to have about 10 or 20 seconds from someone from the group and have a go, and just to have a look and then to have a go. Does anyone want to volunteer? I'll give you guys one.
Wants to give.
Okay, Dave.
Yeah, so I mean, just with that clinical history, the fact that he's febrile was kind of a clue for me. I think, his go, it's narrow. It certainly looks like he's going quite quickly. But what was concerning for me is, it's not the most discernible P waves until he starts. Let me just count it: 3, 4, 5, 6. What, the 8th, 9th, or 10th beat? It looks like, a little bit of a blip on that T wave. Looking in the rhythm strip at about lead 2, or if you want to go there, that's fine.
Yeah, we can go to V5. It's easier.
Yeah, so they're almost looking like, is it a biphasic T? But for me, it's probably a T then followed by a P, which would then give you quite an extensively prolonged PR interval in a first-degree heart block. So in the history of a guy who's febrile, with this kind of feature, it would make me quite concerned for why has he got a first-degree heart block.
And can you guess?
I mean, cardiac thing, possibly an infective endocarditis, in the setting of a prolonged PR interval, then he's been complicated by an aortic root abscess.
You're doing so well right now. If you were right in front of me, I would give you a massive kiss. But in any case, let's just carry on. So you can appreciate that this PR interval is massively prolonged. Now, for first prize, can you guess perhaps maybe so infective endocarditis, yes, but why? And then the second issue is, can you tell me maybe which valve might be involved?
Sure.
Look, I'm really pushing you now.
You asked me why do I think it's infective endocarditis and which valve?
No. Why is the PR prolonged in the infective endocarditis? What's the cause?
So I think you've got an abscess that's now starting to involve the conduction system. So for me, it would be more something in the aortic valve.
Fantastic.
That would be causing your problem. Sorry about that. So it would have to be an aortic root extension.
So why aortic?
Because of its.
You are right. This guy had a massive AR.
Proximity to the conduction system.
Yeah. So good, right? Yeah. So he had, and plus he's also, if you have a look closely, he's also got features of LVH on the ECG. If you look at V1 and you add V5 and V6. So he had a massively dilated left ventricle with torrential AR, and he had an aortic root abscess that we picked up later on TOE. But the other point is that so the main point here is to have a look that if you can't see the P wave, have a look inside the T wave here, and you can see that the patient's got a massively prolonged PR interval patient had an aortic root abscess, and that sort of invaded the conduction system. Excellent, Dave. Okay. All right. So that's the point there. Let's move on to the last one. So this guy over here, I was doing the round in C1D West, and we were called to the trauma unit. It wasn't your time when you were there, Henny. But in any case, this guy he was an old lady, and she had an episode of syncope, and she had fractured her C1 and C2, and she was decided for conservative care, and she got sent home. She presented again to trauma, having fallen down again, and this time she fractured C5 and C6. And then there was quite a smart orthopod who somehow managed to get hold of a stethoscope, and then came running across to us and said, "Listen, can we come and see the patient?" So we went. We had a look at. We examined it, and we had a look at the ECG. Does anyone want to have a go at the ECG first, and then to tell me why is the patient having syncope?
Put his hand up.
Kakiso?
Hi, sir. I'm thinking, given the history of syncope, I was thinking possibly AS, and then when I look at the ECG, it looks like she does have LVH with the T wave that looks like a spreading pattern.
Yeah, excellent, right? So I'll be quite quick because then we can get through to your guys' questions. So you can appreciate, for example, in lead AVL, like you can see AVL is massively tall, right? So if you look at the AVL criteria for LVH, AVL being more than 11 millimeters, the L for AVL and the 11, so you can try and remember it like that. The other criteria also is that you can see that if you take just the baseline Sokolov-Lyon criteria that we all are aware of, so the S1 in the S wave in V1 plus the R wave in V5 or V6 being greater than or equal to 35 millimeters in a patient over the age of 40, you can see there's an associated strain pattern together with that ECG. Right. There's just one other criteria that's coming in vogue that I just want to remind you people of, because you must remember that ECG criteria. So for left ventricular hypertrophy, the gold standard is echo, but ECG criteria for LVH has got a very poor sensitivity but a higher specificity. And a newer criteria that's got a higher sensitivity and a higher specificity for LVH is what is known as the Piguero-Lopresti criteria. Piguero-Lopresti, right? And that basically is the S wave in any of the precordial leads plus the S wave in V4. So here, if you have a look at the S wave in, for example, V3 is big, plus the S wave in V4 being greater than or equal to 23 millimeters in females and 28 millimeters in males, right? And why that happens is because with the left ventricular hypertrophy, I'll show you on this on this little pic over here. So if you have a look over here, this is where the left ventricular mass starts to increase, and then so as the left ventricular mass starts to increase over here, V4, instead of normally having the R wave, because the mass is increasing towards the lateral side, V4 doesn't see an R wave anymore. V4 starts to see an S wave. Can you guys appreciate that? Instead of V4 normally seeing an R wave, because the left ventricle starts to become thicker towards the more lateral side, it doesn't see an R wave anymore. It starts to see a bigger S wave. Okay. So that's the Piguero-Lopresti criteria for LVH. It's got a higher sensitivity and specificity than any of the other criteria. I am busy with MED with one of the registrars where we're trying to validate that in the South African population. So maybe just keep an eye out for that. Okay, so that's it from my side, from Jacques, Kamil, and myself in terms of the talk. What we're going to do now is that we're going to go through some of the registrar questions and ECGs.
All right.
Yeah, I think we should kick off, right?
Yeah, let's go, Cameron. So, there we go. Sneaky.
Jacques, before I forget, maybe through one of these ECGs, if you can explain your Malan sign again to me and to the rest of the group.
Yeah, no stress. Okay, so I'll take a stab at this one. So just let's go through the history. So no matter how much we get scan hearts, get clever at ECGs and X-rays, you just look at that history. 25-year-old previously well, and that immediately should sort of open a few boxes in your mind for an antenatal visit. Send down to the EC. It would have been nice to know, how far, if it is, if it's a 6-weeker or, they for their first check, it's a 20-weeker or 38-weeker, that sort of gives you send down to the ED with a bit low BP. Cold clammy. So cold clammy just slots in your mind, must open patient is cold clammy. So they're not perfusing well. So, that's one of the danger signs. So you need to do something. So, if I have a quick look at this ECG, it looks irregular. It's going super quick. So we need to do something. So a few things sort of crosses my mind immediately. The first one is 25-year-old previously well. Who wants to, what do you guys think is going on with this ECG? Anyone?
Kamil.
There's all the other registrars. Neville, word wakker. What do you guys think?
So I'll give it a bash.
There we go, Neville. Step up to the plate, brother. Put that black label away. Yeah, go for it.
So first off, it's a concerning ECG. Just by virtue of going very fast, she's got a rate of about 150. If I must just eyeball.
Yeah,
so
be a little quicker. Yeah, but sort of there's 150s and there's 180s. Yeah, cool, mate. Yeah.
No, so I would jump to immediate electrical cardioversion straight away. Without a mom, there would be no baby. It doesn't matter which trimester the mom is in, and then probably go backwards from there to see what the cause was.
Okay, good. Let's say, so, obviously, let's say if it's a 38-weeker, sedation becomes fairly interesting. You've got a big belly, the airways, obviously, the tongue is a little bigger, they're pretty swollen. I just think, from an ECG and a patient perspective, sync cardioversion is definitely on the cards. And I think we all agree with that. Well, the biggest thing I've always found in, working in the ED, sometimes we just need to breathe. Take that moment to, we've decided that the patient's probably in rapid AF. They're perfusing poorly peripherally. The BP is low. So we need a rhythm strategy here. Okay. Eva, what do you think? She's 25-year-old previously well. What could have caused this AF, mate? What sort of crosses your mind?
So previously well to me generally doesn't mean anything. It just means that they might have never been able to present to a healthcare facility.
Yeah.
But this might be an unmasking of a mitral stenosis. So I would think of something like a valvular AF.
Yeah, that's what I'm saying. If it's a 30-weeker or 28-weeker, with sub-Saharan Africa, rheumatic heart disease is still there. Could this be the, a mitral stenosis? Yeah, good. In a big mitral stenosis, you all of a sudden whack some electricity and there's a big clot sitting in that left auricle and the mom has a stroke. So, but then you can tell me, Jacques, but, it's life over the limb, the patient's not using their brain. So, valvular heart disease. Anyone else? Neville, what other differentials do we have?
Just based on pregnancy, something like a PE.
Yeah, good. So AFP can definitely think. So just always think a massive PE will give you a right axis RBB kind of morphology. You might have some inferior ischemia going on. So definitely a big PE. So you're obviously going to examine the legs quickly. Think about it. Yeah, good one, mate. But let's say the patient really was previously well. Really well. No jokes. Is there anything she might have had on board before? Yes, what is that? The 3-letter word, not the one I'm thinking of. Yeah? So could the patient have underlying Kagiso? So Kagiso's put in the chat.
Yeah, so could this patient be having WPW?
Yeah, so a person that's previously well, have Wolff Parkinson White, and all of a sudden go into atrial fibrillation, it gives you this QRS morphology that changes. You can actually see it. Probably the best one to see it is there. Just if you look at the rim strip, the one just after the SVAR that's written there. If you just look above it, you just notice that the QRS morphology is a little broader. All of you will ask us, is there any way to know on the surface ECG when it's going fast that this is WPW? No, definitely not. You know, if you can see a nice delta wave, yeah, by all means, you know, pat yourself on the back. But I don't think anyone is going to be brave enough to say that this is WPW before doing that, you know, just on the surface ECG. Anyone, anything else? What else would you think of? Anything else potentially? A patient's got a big goiter, for example. Yeah, so thyrotoxicosis can also do that. Okay, good. So Cameron, I think you want to show the next ECG, mate. Okay, so any clues? So what, Cameron, just I want to ask, what did they do for the patient? They smoked the patient, cardiovert the patient? Cameron? Okay, so...
Sorry, can you hear me?
Jacques, it says posting.
Yeah, they did cardioverter.
Okay, do you have any idea how much they used?
I can't remember exactly. I think she had etomidate and she was cardioverted.
Okay, yeah, all right, good. And that's pretty good. Anyone else, any other options? Pregnant patient, what else can you use? Sedate the patient. It does add a little bit of flavor to it, the patient being pregnant. Yeah, anyone else? Would you guys use ketamine in a rapid rate?
No.
Yeah, I must say I'm also, you know, that's probably the one time I don't like ketamine that much is in your tachydysrhythmias and that. Would you use propofol?
It's a possibility.
Okay. Would you give the patient? Would you? I think the propofol in this case, just be very careful. You know, don't go whacking 200 milligrams of propes. You know, you're gonna run into trouble. I think sedation always should be done. You know, have some care with it. I think we sometimes, being EM, you know, your leg is always half chewed off by a medical registrar. You got someone screaming in your one ear. You know, just give the sedation a little time to work. So, you know, go a little slower, especially if you have pregnancy on board. You know, just be careful because you can run into airway things pretty quickly with that. So, yeah, I think etomidate is probably not a bad option, although, you know, a lot of people vomit with etomidate. You know, I might have carefully just given a little bit of propofol and, you know, see how it goes. Yeah, good, great case. And all the registrars happy, the 3 signs of Wolff Parkinson White? Let me just go back once. Okay, so short PR interval. Okay, QRS that is broad, it can mimic a bundle branch block. All right, and then it's slurring of your QRS, the delta wave. And those are normally nice clues. And there's, you know, for me, if you can pick it before on that previous ECG, you know, rock star, you know, good on you. But I think, yeah, Dr. McAlpini, go for it, mate.
When you're Wolff Parkinson White, when you've got a fast AF with it, isn't it normally broad because it's not going through your conduction pathways? It's got its own pathway. So wouldn't it be like an abnormal rather than a narrow?
You can go down both, mate. just remember that it's still, if you look where your accessory pathway is between your atria and your ventricle, if you go into AF, because you've got this chaotic depolarization of your atrium, the signal can either choose going down the bundle of S, your normal pathway, or via the accessory pathway. That's why you can get broad and narrow complexes at the same time. So whenever you see an irregular rhythm with broad and narrow complexes, then you really need to think about WW. This example actually is almost all narrow. There was one or two that almost looked like little fusion beats, but other than that, no. I'll maybe actually have a good example of one that gives you narrow beats and broad beats. So what Dave is angling at is, if it goes down the accessory pathway and your ventricle gets conducted, and then it means almost like a VT, if you guys can imagine, the ventricle will slowly depolarize because it's not traveling to the ventricle via the bundle of S. It goes via your accessory pathway, and depending if it goes down the right or left ventricle, it will either give you a left or right axis, but your QRS will be broad, and that's your orthodromic conduction or your antidromic conduction. Your orthodromic conduction is obviously when that entry circuit will happen via your normal bundle. Now it's gone into AF, so it can fire down either or, because the problem is actually above the re-entry circuit. Yeah, good question, mate. So yeah, you can see both. This one is just, for some reason, choosing to smoke down into the ventricles by the normal pathway, yeah?
Perfect, thanks,
And
Jacques.
Just to make a comment there
and
as well.
ischemia. Yeah, good boys.
Yeah.
Like the one, Dave.
Just to add to Dave's question, I mean, we have something called concealed pathways in WPW. So pathways, accessory pathways don't always conduct, and we call those pathways concealed pathways. So there may be anterograde conduction down the accessory pathway, but no retrograde conduction, or vice versa. So that could be the reason why you're not experiencing complexes that have different morphology, so narrow and wide.
Cool, but that's normally when it's a re-entry circuit. This one's an AF, so yeah, but good point, mate. Yeah. Next. Oh, my favorite. Okay, so hypertensive 60-year-old male smoker, second episode of heart beating in his ears in the past 10 years. Yeah, is he married? I'm just teasing. Yeah, anyone wants to have a go? Where's some of the other registrars? Who wants to have a go? I can't see all the names.
Jacques, maybe let me help you. I think, let's see. Guys, I think, this is a good time for you just to try out and just suggest, even if you don't have a diagnosis, just start with something as an approach. What about you, Risa? Do you have anything to say about this ECG?
Hi.
How's it?
Hi, how are you? So, wide complex ventricular tachycardia.
Okay, so wide complex tachy, yeah, and you're leaning towards VT, good. Okay.
The patient stable or not?
The history doesn't tell us, but let's say he's stable. He's telling you about these pleasant last 10 years between 50 and 60. Yep.
Okay, and then I don't know.
What would you do in the ED? The patient's there in front of you, he's lying in the recess at Kaya.
So you need to rate.
Say again?
So stable or unstable? You say stable.
Yeah, he's stable. Unstable is easy. Yeah, he's stable for
so
now.
You want to synchronize. Well, he's now stable, so you'd want to rate control him.
Yeah.
And you would.
So what do you think it is? What's your differential for wide complex regular tachy? So you mentioned VT, so that's about 75%. And because it's 60 and he's hypertensive, the likelihood of this being VT, just from an etiology point of view, is high up. Yeah. But for the rest of the guys, all that I mean by that, you need to always think about the why. So, if you're thinking VT, broad complex, it's 60-year-old male, maybe he's got an old ischemic focus, and he's got it. Yeah. So what would you do? Yeah, Sa'ad is sleeping there at Kaya. You can't wake him up. He's had no coffee for the day. What are you going to do?
So you think about a supraventricular tachycardia?
Yeah, with a bundle. Yeah, cool.
Punch block.
Yep.
Drugs. So you obviously want to know your potassiums.
Good. Moisture, potassium. Yeah, it's a good one. Yeah.
And then, yeah, so.
Okay, so potassium is 4. The guy's blood pressure is about 140/80. And you're faced with this rhythm. What's your next step?
You need now to rate control him. So I would go with medical rate controlling.
Yeah. Okay, so anything on the ECG that makes it more likely to be an SVT with a bundle or VT? Is there any clues on it?
With the bundle, so you've got the wide complexes, and then also in V3 and V4. What is happening?
Yeah.
And V5, there's wide complexes with an M shape.
Okay, good. So remember what Sa'ad said. So if you're faced with a bundle branch block, you need to sort of think what is normal and what is abnormal. If you look in V4, V5, and V6, so you have an RSR pattern, all right? So
what looks like depression of the T wave.
Yeah, so normally, remember, if you have a bundle branch block, what up goes down, so the QRSs are upright in V4, V5, and V6, and the T wave is down. All right, so that's your normal appropriate disconcordance. So I think your initial answer is perfectly correct. You'd want to synchronize cardio with the patient. You know, for me, always faced with a wide complex tachy, they're only stable for a very short time, and then they become unstable. Is there anything else on the ECG? How would you sort of start sleeping, no coffee in him? What would you do? Is there any other things that on the ECG that might point you toward VT or SVT with a bundle branch block?
Raisa, I think Elmarie might be putting her hand up to help you. I think she's got something. Do you wanna?
Raisa was doing cool. Well done, Raisa.
No, she can go ahead. It's fine.
Kom Elmarie, gooi.
Sorry, so it might be a little bit noisy where I am. Interestingly about this VT, SVT thing, I'm a new reg, so it's my 3rd month, and we learned quite a good approach versus VT versus SVT at Paul, and there was a few things to look for. The first thing was if your QRS is very broad, so all these things are in feature of, so I say in favor of VT, the very broad QRS, the AV dissociation, your capture and your fusion. If there's a Brugada sign or your Josephson sign, what was the other thing? The positive or negative concordance throughout the chest. And then the absence of your typical bundle branch block. So I just noticed there in V4 is quite a nice Josephson sign.
Can you tell me a little bit more about it?
What is it?
Yeah, what does it mean for you in your mind? So, and what Elmarie is getting to, so remember, normally when you have a bundle branch block, you'll have the first part will be narrow. So Josephson sign is normally, if you look in standard lead 3, it's in the negative, the first part of the negative wave that goes down, there'll be a bump. Okay, Marriott sign is when it's positive. So Josephson sign, all that it means, the conduction going from the bundle of S to the bundle branches, all right, is wide, and there's a delay in the conduction, so that the signal we think is originating from the ventricles. So you've done awesome. So too wide makes you think VT is more likely. Abnormal axis. What do you guys think about the axis of this ECG? Normal, abnormal? What's happening in AVR? Elmarie? AVR, what do you think about AVR?
So AVR is upwards.
Yeah, is that good or bad?
I must say, when I look at my access, I'm used to the normal presentation of how the leads are set out, and now I can't establish if it's
Yeah.
the second lead I look at.
Because we're expecting AVR to be somewhere else. But if you think about it logically, AVR looks at the heart from which angle, right or left?
From the right?
Yeah, so the signal is traveling towards the right side. Is that normal?
No.
So remember, if you're not, no, so it's completely bizarre. So axis is useful. So if we have a look just at right axis and how wide it is, already just from those three things, we're thinking this is potentially going to be VT because the signal is traveling towards AVR. It's positive in AVR. So remember, if the signal is coming from the ventricle at the bottom, you know, it moves towards AVR, it's a nice clue that makes VT more likely. And if you guys have a look at the AVR Brugada only criteria, you could probably stop there and say this is VT, that's fine. You also mentioned some very good pointers. So remember, there's Verikai, there's Brugada, there's a whole bunch of criteria where you, if you have time, and this is a big thing to remember, if you have the time to scrutinize the ECG and in a wide complex tachy, because no heart with a bundle branch block likes to be in SVT. No heart likes to be in a wide complex. So, you know, like Neville said, you know, the patient needs cardioversion. Yeah, by all means, they do. And you can then obviously have a look at the ECG afterwards. And it's all got to do with shape and morphology of your QRSs. And is there the three things you mentioned? AV dissociation. So is there non-conducted P waves? And a nice place to look for it is always in V1. Is there fusion or capture beats? And it would have been nice to have a rhythm strip. But if you look at standard lead 1, there you can't really see any obvious fusion or capture beats. And then is it a normal left or right bundle? Okay, and that would be the next question. The positive and negative concordance, what Elmery meant there, if all the leads looked like standard lead V2 from V1 to V6, that's VT proven otherwise. If all of them looked like standard lead 3 from V1 to V6, that's VT. You can stop there. So when you're faced in the middle, 2 o'clock in the morning, and you're not sure, and you're faced with a wide, complex rhythm, okay, rather err on the side of caution, synchronize cardiovert the patient, okay, always check the potassium. If you think it's a toxidrome, things that commonly cause wide complex rhythms is obviously hyperkalemia, all right, and sodium channel blockers, maybe give the bicarb before if you think it's toxidrome, and then safely sync cardiovert your patient. And then the next step is obviously to have a look at the next ECG. Raizan, Elmery, well done. I like that. That's really a nice approach. Yeah. Where's the next ECG? Did you cardiovert? What happened?
Actually, Dave is on the call. Dave sent this ECG in. Dave?
Okay. Cool. All right, maybe pop on to the next one so long, yeah?
No, so essentially he was sent in, and he had a similar episode 10 years previously. The big cheeses of cardiology had a look at him and decided, look, there's not really much they're going to do from it. May well be SCAR VT that he's got there. Yeah. He didn't think he was eligible for an implantable device, so he was basically discharged on amiodarone.
Yeah.
And
you know, if I was to take a guess, you know, looking AVR and going through it quickly, my money would have been on VT all the way through the bank. Yeah.
I think that the plan was just to get exactly the discussion that we kind of got, and thanks very much to Elmery for what she sent in the group. Yeah.
Cool. Well done, guys. That's really, like, guys, always, you know, take that pause and remember that synchronized cardioversion. Big thing always to remember, you got, you know, sedate carefully and safely, and cardiovert with reassurance. It's a, you know, if you give nice sedation, you know, unless the patient is crashing, and then you just go for the defib, you know, then, you know, but if you control the airway okay, and you're careful with the sedation, and you know, place your pads or paddles correctly, you're going to win 90-95% of the time. And if you're not winning, the thing doesn't want to hop back, just think toxidromes. Yeah. Sa'ad has actually caught me out not telling me about a carbamazepine patient once, and I cardioverted the patient way too many times. Yeah. Cool. Next.
Let's look at the history. So this ECG was sent to us from a referral clinic wanting advice. So just on the history, 53-year-old female, type 2 diabetic. Already I'm concerned, smoker, so significant risk factors already, potentially for ischemic heart disease. Ongoing chest pain started 3 hours ago. All right, and you have an ECG in front of you. I presume they haven't done serial ECGs. This is the only one that they've sent with the patient. So yeah, whoever wants to have a go at it, let's take a try. Kagiso?
All right. I think from the history, the risk factors and the chest pain. So what is worrying me about this ECG is that if you look at, I think this is a De Winter. If you look at V2 and V3, I get a feeling that there's like that ST depression with an upright fold T wave that is consistent with De Winter's T waves, which is a semi-equivalent essentially.
Yeah, I must say, you know, I agree with you. So a few concerning things. If you look at V1, there's obviously an upright T wave there that looks quite, you know, of significant amplitude. I'm trying to see if this patient has any LVH by standard criteria. So just looking at AVL, it is a female patient, so I'd be looking at an AVL R wave of more than 9 millimeters. So potentially you could say maybe there's some criteria for LVH. But again, as Sa'ad said, that's not very, very sensitive because obviously an upright T wave in the presence of LVH, you know, is acceptable. And the reason I'm saying that is because, you know, of this T wave inversion that I see in V6 that made me think, you know, of the potential of LVH on this ECG. So let's just move down to the rest of the precordial leads. So I agree with you. Some J-point depression in V2 with a hyperacute T wave, very suggestive of a De Winter pattern. And then if you look at V3, there's definite J-point depression with the horizontal sort of ST segment depression extending down to V4 as well. So I must say when I initially looked at this ECG, I was thinking, you know, could this be a posterior infarct? Could be. You know, you don't necessarily need to have ST depression with inverted T waves. You can even have an upright T wave and it could still be a true posterior infarct. And then just looking at the ECG company, inferior leads, there's definitely T wave inversion inferiorly in 2, 3, and AVF. And also some subtle, or maybe not so subtle, ST segment horizontal depression in 1 and AVL. So definitely looking at an ischemic ECG, and yeah, you know, I would say this is a hyperacute De Winter pattern in V2, but still want to get posterior leads on this patient. Sa'ad, any comments from you on this ECG, mate?
No, I think you've covered all the main aspects with regards to it.
Yeah, Jacques?
Yeah, I think just on the T waves, E2 is obviously completely open. That upsloping patient, you know, hyperacute wave there. Just that comment I made earlier, just subtle signs of ischemia, and they're normally fairly subtle. You know, the upright T in V1 must dominate the T wave in V6, and what I mean by that is, you know, this one is, you know, that T wave is massive, but I do think it's sort of, if you flip V6 around, you know, don't tell Ike the exam, I'm going to flip the V6 around. They will look fairly similar. Only if it's an ischemic T wave in V1, it will be up and you'll have the subtle flattening in V6. That's normally a nice ischemic, you know, one up that's upright. But I want to say that looks like a De Winter T wave. I'd repeat that, you know, that's going to need reperfusion. It's got all the risk factors, you know. Yeah.
Yeah, so again, an ECG that doesn't meet traditional STEMI criteria, but is considered a STEMI equivalent. And, you know, this ECG would be enough, you know, to activate your reperfusion strategy. So Yeah, I mean, I agree with you just with regards to this amplitude of the T wave, and Sa'ad, it would be interesting to hear your thoughts on whether you think this patient actually has LVH or not, using the criteria that you mentioned before. And the reason I say that is because, with LVH, your left ventricle tends to enlarge laterally and sometimes posteriorly. And you can get these reciprocal changes in your V1 and V2, which look like very large T waves. And it's actually just a reciprocal change from your T wave inversion in V5 and V6. So I must say that's what initially made me think, could this be a posterior infarct? I'm still not convinced it isn't. But having said that, I do tend to agree with the group that I'd probably go with this being a De Winter pattern in V2. So yeah, absolutely. I would reperfuse this patient. Comments from the group, if you have any? So, Kahiso.
I was going to say the issue about, the posterior, I know you also posterior MI is another consideration, but it tends to not to be in isolation or not so common alone, isn't it?
Yeah, I mean, isolated posterior infarcts do occur, and these are the subtle ones you don't want to miss. The ones that just present with ST depression anteriorly. I mean, compared to inferior posterior, they're significantly rarer. But I mean, if you have to look at the overall percentage, I'd say about 5 to 10% are true isolated posterior infarcts. So you do see them.
Kamil, so I got this case. This was actually, I got it from somebody else that sent me this ECG, and sadly there was no follow-up because this patient actually demised at the clinic, so we don't actually know what happened. They said she just went into arrest. Out of interest, would you advise, so say you got this ECG and you are in a typical setting and someone asks you, would you advise them to give them lysis based on this ECG?
Yeah, I mean, this is it's a bit of a loaded question. It does depend on your setting and where you are, Kamil. So, we need to follow sort of like, standardized timeframes for reperfusion, right? And if this patient has time to come to you, then absolutely you want this patient in an area that's resourced, potentially has a cath lab, has more resources than a clinic. But, if someone had called me from this clinic and you've got this patient who's looking sick, with all these cardiovascular risk factors, I would absolutely advise them to reperfuse if there was no other option. And yeah, I'd say go for it, analyze the patient. Do you know, I mean, if just out of curiosity, so this patient, I presume they called for advice, and do you know what subsequently happened? Was the patient accepted? Patient die while waiting to be transferred?
I must say I don't actually remember. It was about a year ago. I think what happened was they must have been accepted to come across, and then when they called back, they said no, she went into an arrest, and I'm not sure what happened. I mean, I don't know what would have caused the arrest, but obviously the QT is starting to look a bit long, and whether she got electrical instability and went into dysrhythmia.
Yeah.
Sure.
I mean, the QT will be prolonged with hyperacute T waves, obviously because of the broad base, so that makes the QT interval longer. And we often see a lot of patients coming in with cardiac arrest, and then when we look at the pre-hospital ECGs, we see this, and then obviously you need to consider, intra-arrest lytics as a last resort. Because you obviously know what caused the arrest. I mean, in this case, I'm pretty sure it was ischemia. So she probably, went into an arrhythmia, probably VTAC or ventricular fibrillation.
Dave Cloty has his hand up.
Yes, Dave.
Yeah, no, I just put it down, but it's fine. Come on, I just want to go through the thought process there. I mean, I understand you notice that look in V1, there's, you've got that loss of the precordial T-wave balance, but there's no LVH, so therefore, it would make it more a true suspicion of an ischemic event. And then just in terms of trying to differentiate between now your ischemic differential here, you've got your De Winters or you've got posterior MI. I know they're both being STEMI equivalent, so you're both going to treat them the same. But wouldn't you lean more towards a De Winters pattern if you've ruled out LVH and you've actually got what looks like, sorry, not so you would lean towards more an inferior posterior event when you've got your T-wave inversion inferiorly and you've ruled out LVH?
Yeah, great. Interesting question, Dave. Yeah, so you're absolutely right. The decision is going to be the same on treatment, right? Whatever it is, whether it's a posterior infarct or whether this is a De Winter pattern, this patient needs reperfusion. Yeah, listen, Q3 and AVF, I agree there's some T-wave inversion, but there's no real ST segment elevation that I can see. Hence my comment that I thought that there was probably an isolated posterior infarct in my differential.
Okay.
But yeah, listen, I'm still going to go reperfuse, whatever it is. Even if it's supposed to infarct, even if it's De Winters, so.
Cool. Thanks very much.
I don't think there's any more comments. Just a word of thanks from my side for our 3 guest speakers. We've taken and exhausted your time and energy, but thank you so much for all the teaching and the polls that you have given us. Thank you to the team members that participated. Thanks for taking one for the team. Some of us don't have that courage. We appreciate that. And then have a blessed day.
Yeah, thanks, Gaudi, from my side for facilitating. Thanks, Lauren and Kamil as well for your input. And yeah, it's been great fun interacting with you guys down in Cape Town. I wish you all the best. Just remember to get better. You just need to practice, practice, practice. You're not going to know everything, but it's the same with us, right? We continue learning every day. Good luck. And if you need any help, you know how to get a hold of us. Bye, guys.
Just from my side, it's good to catch up with you guys again and, enjoy the teaching. You guys are getting great training down there in Cape Town. And, like I said, they stand you very, very good throughout your career. And, yeah, enjoy it. There's tough times. It's good times. Yeah, some laughs, some cries. All normal. Yeah, it's good to see everyone. Gaudi, Hamlin, Lauren, thanks for organizing. Yeah, good to see a few faces. And yeah, you guys keep well. And yeah, we'll chat soon.
Okay, guys. Thanks very much. Really enjoyed it and learned a lot as well.